Thank you. I'm a rheumatologist and I'm always excited to talk about advances made in treatment of inflammatory diseases. Lucian, we do talk a lot about healthy lifestyle choices and anti-inflammatory diet. And this question comes up with every single visit of a patient addressing inflammatory rheumatic diseases. Over the last 2 decades, there have been major advances made in development of new treatment options that have changed the natural course of most of inflammatory diseases. Also, the treatment approach has changed significantly towards earlier and more aggressive treatment options. And that's changing medical and orthopedic approach to managing these patients. Interestingly, with all of these changes, the rates of arthroplasty in inflammatory diseases has remained pretty stable. Non-inflammatory needs for joint replacements have increased dramatically, but the inflammatory rates remain stable. If we look more closely, however, we do see some changes showing that patients undergoing the surgeries later, especially with juvenile rheumatoid arthritis and spondyloarthropathies. The age for the surgeries has become later. For osteoarthritis, we see younger patients are undergoing these procedures. Other trends show that small joint procedures have decreased significantly, including hand and foot surgeries. Still, a significant proportion of patients with rheumatoid arthritis requiring orthopedic procedures. Up to 60% of patients will need to undergo surgery over 30 years. The rates have been increasing for other conditions, including lupus, spondyloarthropathy such as psoriatic arthritis, and ankylosing spondylitis. When we compare the technical aspects as well as all medical and post-surgical parameters for our patients with inflammatory diseases versus patients with degenerative diseases such as osteoarthritis, there are some significant differences. Unfortunately, the risk of complications is higher for inflammatory diseases, and that's due to the nature of the conditions as well as the medications used. And those complications include increased risk of DVTs, need for blood transfusion. Patients with inflammatory diseases may have increased risk of heart disease, and we see more cardiac complications. And the risk of infections, all infections, including pneumonia, sepsis, wound infections, seem to occur at a higher rate. Looking at the readmission rates, especially for patients with rheumatoid arthritis and lupus, and most of those readmissions are due to infection, are definitely higher in comparison with patients who had similar surgeries for osteoarthritis. Looking specifically at spondyloarthropathies such as ankylosing spondylitis and psoriatic arthritis, we also see increased risk of infections. More specifically, there is increased risk of respiratory complications, and that is due to part of the condition that involves fusion and inflammation in the costovertebral joints and the fusion of their spine that restricts the chest wall expansion and increases the risk of respiratory adverse effects. From the mechanical standpoint, there is also an issue with high risk of dislocation and fractures of the spine, as well as the fractures around the surgical site. And that's due to increased risk of osteoporosis in patients who have ankylosing spondylitis. That may often go unrecognized, as many of those patients may be men or at younger age who normally would not have a bone density test. Another complication that is very specific to patients with this condition is heterotopic ossification. It is the formation of bone in the soft tissue where bone normally does not form. Most patients undergoing knee or hip replacement who have rheumatoid arthritis will be on medications. And the main treatments that are used for this condition include DMARDs and biologics. DMARDs work by lowering overall inflammatory response of the immune system. These medications generally have a lesser side effect profile and definitely a lot less expensive than biologics and remain the first line of therapy. Biologics are the medications that are genetically engineered based on the human genes that target more specific steps in the inflammatory process, blocking inflammatory proteins called cytokines. And those include TNF-alpha, IL-6, IL-1, and those medications are more expensive and tend to be more immunosuppressive and require particular considerations when used in patients, especially undergoing surgery. So most patients will be using either DMARDs or biologics or a combination of both. Even though these medications are very extensively used, still a lot of patients with rheumatoid will be using steroids either chronically or intermittently. Patients with lupus use similar medications and also other immunosuppressive medications that need to be taken into consideration around the time of surgery. And medications is something we can control, and that's important because that allows us to lower the risk of complications after surgeries. Interestingly, more recent data shows that use of some of those medications that historically have been believed to be problematic for surgery because will lower somebody's immune system and therefore they will be at risk for developing infections, DMARDs and especially methotrexate actually were shown to decrease the risk of wound complications and infections compared to patients who would stop those medications. And also patients seem to have better recovery because they were having much lower risk of flares. In hand surgery series, comparing patients who took DMARDs and NSAIDs, there were no difference in adverse outcomes compared to patients who did not take those. There were no specific studies looking at what happens with biologics because generally we tend to stop it if we can. But there were some studies showing that there was increased risk of wound dehiscence in patients who stayed with especially TNF drugs. Steroids. Most physicians and patients always have love-hate type of relationship with these medications. They're very effective. Also, they carry a significant risk of different side effects. And even a small dose of 5 milligrams, especially over a period of time, and the longer the time frame of use, the higher the risk of infections. And those infections include surgical risks as well. There is no good way to determine a safe dose, and some patients, especially who've been on these medications chronically, we cannot stop, but making an attempt to lower the dose will definitely help with the recovery and minimizing possible complications. We do know that the dose at 15 milligrams or higher per day carries a higher risk. So in effort to provide some guidance as to how we should manage these medications, the American College of Rheumatology has partnered with American Association of Hip and Knee Surgeons and tried to develop guidelines how to manage these medications in patients with inflammatory rheumatic diseases who electively plan to undergo total hip or knee replacement. And it involved a panel of orthopedists, rheumatologists, and what I found it was very important, a lot of patients who also contributed to decision making as to what to do with these medications. And they did use some evidence based on prior studies. However, a lot of it was based on expert opinion and just general observations. There are some plans being made to have some methodology and prospective data analysis to give us more guidance. But as a result of these guidelines, we do know that all biologics should be stopped prior to surgery. Ideally, we'd like to schedule the surgery based on the dosing cycle. Some of those medications are used daily, some used weekly, some used monthly. So ideally, we want to plan the surgery towards the end of that cycle. We do know that there is an increased risk of infection with all of the biologics. The higher the dose, especially if the dose is higher, what's the standard dose may be, the higher the risk of the infections. The risk may be lower with a lower dose, but nobody wants to take chances, and the attempt is always made to stop those medications. We used to calculate the timing when we should stop and restart medication based on the serum half-life, but looking at the dosing interval seems to be just as relevant and more practical, and that's what we use now. All of the considerations around the surgeries, we do know that it's important to have orthopedists, rheumatologists, and internists working together, trying to get the patients ready for the surgery to assure the best outcomes. Infections are common, and the best effort should be targeting optimizing the disease control. People who have surgeries in the middle of the flare will have harder time to heal and recover. So everything that can be optimized prior to surgery should be optimized. The dose of the steroids should be lowered. The need for stress dose steroids is not as important as it used to be, and most people do very well just continuing their daily dose of the steroids, and that seems to help with lowering risk of infections as well. Traditional medications such as methotrexate and sulfasalazine, leflunomide should be continued during surgery, and biologics should be stopped. So to summarize, the rates of orthopedic procedures in patients with rheumatic diseases remains high, and these patients have very complex medical and orthopedic issues that need to be addressed by all specialties involved in the care of these patients. Most patients will be taking medications, DMARDs, biologics, or a combination of different treatments, and the adjustments should be made prior to surgery. Additional factors as duration of the disease severity, and complications that may be related to the disease itself or the medications all contribute to planning and optimizing the surgeries. And it looks like that over the next 5 or 10 years, we may actually see more of a change in the rates of surgeries. There's always a lag time when these medications get approved before they come into more widespread use, and how well we can protect the joints remains to be seen in years to come. Thank you.